Hello everyone, my name is Kyndal Shaddox and I am going to be presenting my DNP project that focused on implementing sedation holidays in the acute care setting. The purpose of the study was to determine if implementing daily sedation interruptions for adult mechanically ventilated patients in the intensive care unit would decrease their length of mechanical ventilation. So a little bit of background about this topic is that continuous sedative infusions are often used in the critical care setting for those requiring mechanical ventilation. Sedative medications are needed to help ease the ICU experience by relieving the patient's anxiety and agitation. Sedatives also work to reduce pain and discomfort, help with ventilator tolerance, and stop patients from removing life-saving medical devices. However, using sedation has also been correlated to risks. Continuous sedation has been linked to prolonged mechanical duration, longer ICU and hospital stays, higher mortality, delirium, pneumonia, psychological disturbances, and some strategies have been developed and proved to be effective in reducing the dangers associated with sedation. One strategy for reducing the risks associated with sedation is utilizing a sedation holiday. A sedation holiday or a sedation vacation is described as a continuous sedation infusion that is temporarily stopped for the same time each day. Daily sedation interruptions decrease the amount of medications in a patient's body. As a result, patients are more alert, awake, and it aids in the facilitation of their capability to breathe on their own. The sedation holiday allows an opportunity to assess the patient's neurological status, weaning of sedation, and extubation readiness. However, certain dangers have also been associated with sedation holidays. Decreasing sedatives can cause the elimination of life-saving medical devices or cause additional hurt, distress, or anxiety. The agitation has been correlated to outcomes like removing endotracheal tubes, catheters, promoting larger oxygen demands, ventilator dysynchrony, and PTSD, or post-traumatic stress disorder. Some reports have been discovered that the sedation breaks lead to larger doses of medications being used and healthcare employees reporting feeling overburdened or overworked. Some physicians are hesitant to use a sedation holiday method due to the possibilities and dangers it can potentially cause. As you can see, there are both advantages and disadvantages to each preference of sedation usage. There are many benefits that could result from implementing daily sedation holidays. Sedation holidays could standardize care through the titration and management of sedation, cut healthcare costs, and aid in the process of ventilator liberation. Implementing a sedation holiday protocol could also potentially lead to decreased time spent on a ventilator, decreased days spent in the ICU setting, decreased length of the patient's hospital stay, decreased morbidity and mortality. Completing this DNP project aims to promote positive patient outcomes throughout the ICU population, implement change, translate my research into my practice, improve the healthcare at my facility provides. It could also standardize sedation use and lead the way towards future innovations. My PICO question for this project was that the population intervention comparison and outcome question would be: in a critically ill medical ICU adult patients, does daily sedation interruption compared to no daily sedation interruption reduce the duration of mechanical ventilation? The purpose of my scholarly project was to implement daily sedation holidays throughout the 10-bed medical intensive care unit over the time frame of a month at a level 1 trauma facility in the Midwest region of the United States. I collaborated closely with the medical ICU nurses, critical care team, and physicians, providers, residents, respiratory therapists, educators, management, the director of the ICU, and the research administration. A quantitative exploratory design was utilized for this project. Participants were not engaged. A retrospective chart review was utilized to compare pre- and post-implementation. Electronic medical records from the medical ICU were used for the data collection process. As a researcher, I recorded the minimum necessary data to accomplish the goals for the project on the data collection sheet. All potential patient identifiers were removed. The following strategies were implemented to improve the managing of sedation process for ventilated patients. An educational intervention was presented to all providers, nurses, respiratory therapists, managers, educators, and the director that included evidence-based practice guidelines for sedation use. A section in the medical record was created to initiate a sedation holiday and record results. A Richmond Agitation Sedation Scale, or ROS scale, was readily accessible to calculate the sedation level for each patient. A step-by-step outline for the project's protocol is as follows. Step 1 involved participants not being engaged. The project was completed using a retrospective chart review. Step 2, IRB approval was obtained from Maryville University and my facility. The data collection process began by obtaining a list of patients who were mechanically ventilated in the medical ICU ages 18 to 80 years of age from May 1st, 2022 to May 31st, 2022. As a researcher, I reviewed each EMR to determine the inclusion criteria had been met. Each EMR was then used in this project, was given a numerical number. The electronic medical record was assigned a number on the data collection sheet. The minimum necessary data was then collected on the data collection sheet to achieve goals of the project. No patient identifiers were included in the data collection process. The data collection process was stopped once the anticipated required 106 electronic medical records was met, or the time frame of a month had been complete. Inclusion criteria for patients in the electronic medical record for the data collection process were the following. The patient was 18 years of age or older, was younger than 80 years of age. The patient was requiring mechanical ventilation. The patient was being managed by the critical care team, and the patient was being given sedative agents on their MAR. The exclusion criteria for the patients included data collection for the following. If a patient was older than 80 years of age, if the patient was younger than 18 years of age, if the patient was not receiving sedative agents, if the patient was receiving a paralyzing agent, if the patient was having active seizures, if the patient was going through alcohol withdrawal, if the patient had experienced cardiac arrest for their current hospitalization or less than 24 hours since the cardiac arrest event, if the patient was at risk for an elevated intracranial pressure or head injury, if the patient's ROS score was greater than 1, if the patient was hemodynamically unstable, if the patient was pregnant, or if the patient had a tracheostomy. So one of the instruments for this project included the Richmond Agitation Sedation Scale, or the ROS scale. It was one of the most valid and reliable sedation assessment tools available. The ROS can be used in all hospitalized patients to describe the level of alertness and agitation. The scale is mostly used in mechanically ventilated patients in order to determine if they are adequately sedated. The ROS scale is effective for deciding if a patient is overly sedated or not sedated enough. The scale itself is used throughout the world and was developed with input from nurse practitioners, physicians, nurses, and pharmacists. The ROS consists of a score, classification, and description to conclude a patient's agitation and sedation level. This scale is frequently used on patients that are mechanically ventilated to assess and reduce the unpleasantness associated with being intubated. Overall, the scale allows healthcare employees to effectively assess, evaluate, and manage a patient's sedation appropriately. Another instrument that was created for this project was a sedation holiday algorithm. This was created to assist the project implementation and learning process. This algorithm provided easy-to-follow instructions for how to properly carry out a sedation holiday, and it helped eliminate areas of confusion. An analysis of the data was established using descriptive statistics with a sample size of 41 total patients. 25 patients were in the continuous sedation group and 16 patients were in the sedation holiday group. For each individual patient, the number of days that required mechanical ventilation was recorded. This figure represents a box plot for the number of days patients required mechanical ventilation based on the type of sedation they received, continuous or a sedation holiday. Variability of the data collected was determined by the mean for each group of the sedation. The continuous sedation group had a mean rank or average number of mechanical ventilation days of 18.92, while the sedation holiday group had a mean rank or average of number of mechanical ventilation days of 24.25. The total size of the study included 25 patients in the continuous sedation group and 16 patients in the sedation holiday group, making a total of 41 patients that were examined throughout the study. The sample size was smaller and prevented adequate measurement of the expected variability. The data collected for this project was analyzed by implementing the Mann-Whitney U-test. The power analysis of the Mann-Whitney U-test revealed the power of 0.1807, representing a low power. This specific test was performed to decide whether there was a statistically significant difference between this continuous sedation group and the sedation holiday group, relating to the duration of mechanical ventilation. The results of the Mann-Whitney U-test indicated that this difference was not statistically significant. Since the value is greater than 0.05, no significant difference between the continuous sedation and sedation holiday group was noted. There is no sufficient information to say that there is a difference between the two. The above tables reveal the results of the Mann-Whitney U-test by highlighting test statistics and the average number of days spent on a mechanical ventilator for each group. The timeline for this project can be seen here. Basically, this took place from November of 2019 to September of 2022. Limitations for this project included a small sample size, staff reluctance to change, short time frames, staffing shortages, collaboration from many departments, and poor communication and coordination. Other limitations included not accounting for potential affecting factors like admitting diagnosis, comorbidities for individual patients, age, gender, medications utilized, doses of medications, tracheostomy occurrence, reintubation needs, adverse events like self-extubations, length of stay, cost of therapy, morbidity and mortality rate, and family and DPOA decisions that dictate the care being provided. It was anticipated that 106 patients be included in this study. Unfortunately, only a total of 41 patients were included. Even though the results were not statistically significant, findings could be used to help standardize sedation titration, management, and the ventilator weaning process. Patient outcomes could potentially be improved while reducing ventilator duration, length of stay, and associated cost. This encourages that this specific topic needs to be investigated further. The findings were not to be expected, warranting further investigation. Implications for the future. Sedation holidays have been linked to many advantages in helping standardize care throughout the ICU setting. Implementation ensures appropriate management and titration in regards to sedation while assisting with a ventilator weaning process to help liberate ICU patients from the mechanical ventilator. This process eliminates inconsistencies, errors, and gaps in the care being provided to all patients. The project aspires to improve patient outcomes as well as the clinical practice setting. The goal is to improve healthcare in regards to safety and quality for the care of all patients. The project contributes to positive changes being made throughout the healthcare and helps lead the way towards future innovations. And lastly, the project has the potential to enhance future research studies. And here are my references. Thank you for listening to my presentation.